Hello, I am Parul Patel, Global Medical Affairs Director for Cabotegravir, and on behalf of my co-authors, I will present results from our poster. Cab and Rilpivirine have recently been approved in adults as the first complete long-acting regimen for the maintenance of virologic suppression in people living with HIV. In clinical trials, women of childbearing potential were required to use a highly effective method of contraception. We evaluated efficacy, safety, pregnancy rates, and Cab and Rilpivirine PK through week 48 in women with and without documented hormonal contraceptive use enrolled in the Phase 3 FLAIR Atlas and Atlas 2M studies. It's important to note that this analysis included data in women for whom contraceptive hormone use was documented and confirmed by the investigator during the study. Hormonal contraceptive use may be underestimated as it was not formally documented in all women who received hormonal contraception. Among women randomized to long-acting Cab and Rilpivirine, 265 were of childbearing age, of whom 39 or 15% had confirmed contraceptive hormone use. Progestin-only use was reported in 74% of women, primarily from South Africa, with 26% reporting combined estrogen-progestin use. At week 48, efficacy rates were greater than 90% and comparable among those with and without documented hormonal contraceptive use in both the long-acting and comparator ART treatment groups. There were no differences in safety, discontinuations due to AEs, or injection site-related AEs in participants receiving long-acting Cab and Rilpivirine for those with and without formal documentation of contraceptive hormone use. Through week 48, there were 7 pregnancies among 265 or 2.6% of women in the long-acting group and 3 pregnancies among 120 or 2.5% of women in the comparator ART group. Among the 7 pregnant women exposed to long-acting Cab and Rilpivirine, 3 had recorded contraceptive hormone use prior to pregnancy detection. The remaining 4 women recorded using a non-hormonal form of contraception. Upon pregnancy confirmation, all women discontinued long-acting therapy and were switched to alternative ART. Of the 7 pregnancies, 3 had live births with no congenital abnormalities reported among the infants, 3 had induced abortions, and 1 had a spontaneous abortion considered unrelated to Cab and Rilpivirine by the investigator. There were no differences in Cab and Rilpivirine long-acting PK profiles in women with and without formal documentation of contraceptive hormone use, regardless of dosing regimen, supporting that estrogen and progestin-containing contraceptives do not impact Cab and Rilpivirine long-acting PK. In conclusion, despite low formal documentation of contraceptive hormone use in Phase 3 studies, no clinically meaningful differences in efficacy, safety, PK, and pregnancy rates among women with and without documented hormonal contraceptive use receiving Cab and Rilpivirine long-acting was observed through week 48. These findings support the safety and efficacy of concurrent estrogen and/or progestin-containing contraceptives, regardless of administration route, in women receiving Cab and Rilpivirine long-acting monthly or every 2 months as maintenance therapy.